All right, so this isn't going to be the classical case where we go through the labs and the X-rays and all of that hoopla. It basically, I elected to do this because I saw two virtually identical patients within the same week, and it speaks to FRAX adjustment. So the objectives of this are to ask the boneheads to encourage your DEXA interpreters to report what they used for clinical risk factors in their FRAX calculation and have that in the DEXA report. And secondly, to share the effect of FRAX alteration based on family history with you, encourage you to think strongly about using this, and also to keep your eyes peeled for the potential FRAX adjustment based on recency of fracture. And so I think we all appreciate that clinical risk factors have differential effects on FRAX, but which one has the greatest effect? And I think that we would guess that it would be fracture, and it's not. So this is a 55-year-old BMI as you see, T-score as you see, and then checking each individual box. And the one that has the biggest impact on MOF is a paternal or maternal history of hip fracture. And so here were these two patients, and I've homogenized them just to make it easier to think about. A 55-year-old and a 75-year-old with a humerus fracture. They all have the same femoral neck T-score. So this patient, when you put her into FRAX, she had a 15% MOF risk. This one, 27%. The 75-year-old, 22%. Or 38%. And if you followed the ACE guidelines, you'd say, well, you maybe don't need to be treated. Well, you do, you're above 27%. You do need to be treated, and maybe with an anabolic based on this hip risk. And here you clearly need an anabolic, okay? What's the difference between these patients? It's whether we check yes or no for parental hip fracture. Well, that's straightforward, right? You go to the FRAX webpage and it says, you know, inquire about a history of hip fracture in the patient's mother or father. Enter yes or no. How can we screw that up? Well, here's a study that came out of Bill Leslie's group up in Manitoba, published in JBMR now about 5 years ago. The purposes were to look into the association between objectively verified parental hip fracture and offspring MOF and hip fracture, and then evaluate the potential modifying effect of parental age at hip fracture. And it's the usual Bill Leslie cohort study where they studied a gazillion patients, 250,000 offspring, almost 500,000 patients, and they captured the fracture data from hospital records, the MOF from hospital and physician billing, and then looked at parental age and used the youngest age of parental hip fracture. And of course, they studied almost 3 million person years of offspring follow-up, median follow-up of 12 years. And the punchlines are here in the red boxes. And that is if the parent hip fracture was 80 or over, no effect on offspring MOF, and also no significant effect on offspring hip fracture. And as such, they suggested that, well, maybe parental hip fracture occurring after age 80 should be omitted from FRAX. They did comment that they don't know why. I think it's likely that these fractures above age 80, which in fact, as you know, is that roughly the average age of hip fracture, it's probably due to other comorbidities. And so the two patients that I shared with you, both of them had their FRAX calculation initially, including a parental history of hip fracture, one at age 85, one at age 90. And when you get rid of those, you're left with this patient, yes, she's had a humeral fracture, she's osteopenic, MOF risk isn't huge, you might consider not treating her. Or the second 75-year-old, where previously it was a slam dunk, anabolics, maybe not. And as a result of this concept, when you get an interpretation from UW, if the parental hip fracture was above age 80, we are not checking yes, we are checking no. The other concept is we can alter FRAX for a bunch of other things. The glucocorticoid adjustment is out there, the lumbar spine BMD T-score adjustment is out there, which is basically a 10% change per T-score difference. So for example, if the spine is 1 T-score lower than the hip, you multiply the numbers by 1.1. The TBS adjustment's automatic. The type 2 diabetes adjustment is check the RA button. I don't know anybody adjusting by hip axis length or falls history, but this is something that's making a lot of noise, and that is recency of fracture, so-called imminent fracture risk. And these are data that are from Iceland. And notice that these adjustments are multipliers. So for a person who's had a humerus fracture, you multiply the FRAX calculation by 1.96 from age 50 to 60, or by 1.26, or 1.39 rather, at age 70 to 80. And recency was defined here within 2 years. This has a big effect on the FRAX calculations. So our patients, again, if we would have had a recent humerus fracture, we would bump their MOF from 15 to almost 30. And with the humerus fracture, MOF goes from 22 to 31. And I think then if we are going to implement this, this will clearly lead us to using a lot of bone anabolics. And as such, Juliet Compston and Matt Drake published this perspective on this in JBMR last year.
2 minutes.
And very briefly summarizing, the concept of imminent risk is indeed important when we're thinking about high risk versus very high risk and thinking about anabolics. Almost certainly, FRAX underestimates fracture probability in the setting of recent and or multiple fractures, and particularly within the first 1 to 2 years after the sentinel or index fracture. Whether or not we can take the Icelandic data, which is what I showed you here, and apply that to the entire planet, I think needs to be further validated before we start implementing this. And in this perspective, they did some back of the envelope calculations and concluded that if we implement that, that's going to lead to anabolics being used as first line in almost half of women in whom pharmacologic intervention is indicated, which probably makes sense if anabolics were cheap. And as we know, they are not. And they summarize this, and I think it's a good key clinical message that a recent major fracture, particularly hip or spine, needs to be evaluated, as Sarah told us, with early intervention in the majority of folks, and we should be considering bone anabolics. But I think whether we should be implementing this imminent fracture risk adjustment is perhaps premature, so stay tuned. And I thank you.
All right, thank you for your case. Right off, we don't have any questions. Is there any additional comment that you want to make?
So I agree completely, and we don't use above 80, and the recency of fracture adjustment stuff is really important. I just think for clinicians to rely on a technologist to do this for them is probably, I worry about it. Maybe at UW this can happen, but I doubt most clinical centers and hospitals are going to have their technologists spend the time required to do this. And we still have to be doctors. And we have to think about, oh, gee, yeah, this patient had a recent fracture, that changes things. And, you know, if it, I don't know, I think in the 60s, it's like 2.5 times if it's a vertebral fracture or something like that. I mean, we just, I'm not sure, just relying on asking physicians to rely on what the technologist calculates. I never look at those. And I see them done frequently, and they're often quite wrong. Neil?
I agree with you, Joe, and I was just digging a slide up from Bill Leslie, and this is accuracy of self-reported fracture. And, you know, it isn't very good.
Yeah.
So I think that I totally agree with you. The take-home message for folks on this meeting is, if you're going to be driving your treatment decisions based on these fracture estimates, pull up FRAX and do it with your patient and get the right number.
I have a couple questions for you yet, Dr. Binkley. One is just a comment. I agree with Joe. I very commonly get different FRAX results in the office from the radiology report. Can Dr. Binkley repeat what you multiply the MOF risk by in someone with a recent fracture, and what is considered recent within the past year?
Yeah, the short answer is no, because a recent fracture is it was defined in that cohort as within the first 2 years. Fracture risk is highest immediately after the fracture and declines progressively over time. But for purposes of that FRAX adjustment, Canis and Company defined it as within 2 years. They also had different multiplication factors based upon age and based upon fracture site. And if we are ever going to have this be incorporated into our calculators, it's going to have to be something, in my opinion, that the computer is going to do for us. It's not going to be something that we're going to be remembering. So I think that it's something that's going to have to be along the lines of the NOG guidelines, where you just click and the computer puts the X on a chart.
If I recall correctly, vertebral fractures had the greatest risk, and also the older you got, the less that risk was. So it was, if you're 60 and had a recent fracture, the relative risk, not the absolute, the relative risk was much higher than in a 90-year-old who had, or 80-year-old or whatever.
And that's correct. And the huge multiplication factors were women who sustained fractures under age 50. Those were multiplication factors of somewhere around 7. And so what that would mean is that every fairly young woman who sustains a insufficiency fracture would get an anabolic. And maybe that's right. I don't know. But it's something that I think we have to validate before we just say, yep, everybody who gets a vert fracture at age 50 gets Romo.
Okay. Those are the end of the questions and comments.